Good morning, everyone. We are going to be discussing how functional medicine can help reverse diabetes type 2 with Dr. Frank Tortorice. Dr. Frank is an MD who is an award winning doctor from California. He has been working with diabetes type 2 clients for the last 20 plus years. He has helped hundreds of clients reverse diabetes with success. I'm Amita from Nourish Talk, a global platform for natural, holistic, and integrative therapies. I'd like to introduce all of you to Dr. Frank, who's joining us live from Burlingame, California. Welcome, Dr. Frank.
Hi, Amita. Thank you for inviting me to this conference.
All right, so let's just get started. So we are going to be talking about, diabetes, type 2 diabetes. So let's just start from the basics of what is type 2 diabetes and what are the causes and the signs on diabetes type 2.
Yes, so because there's various educational levels, I think joining us, I'm going to try to keep it on a low level. We can always go in depth, but I want to include as many people as possible. So type 2 diabetes is known as an insulin resistant type of diabetes where the cell is unable to take in the insulin. So insulin is needed to shuttle glucose into the cells. So it's called insulin resistant diabetes. Basically, the cells have become immune to insulin. The body initially increases the amount of insulin to try to get through. And when that doesn't work, then what happens is the patient's blood sugar goes up and there's less sugar inside the cell.
So is type 2 diabetes genetic, or is it, being inherited?
It's debatable. Type 1 is thought to be genetic for sure. Type 2, I think we're seeing is it may be autoimmune. Okay, so it's a little controversial and it's kind of newer science, but some patients have a limited ability to be able to take in the insulin into the cell. So I'm not sure there's a gene type associated with it, but certainly a patient's genotype does have a role in that. I think you can say that it's not caused by a gene mutation, so it's not that type of genetic. But the genes are more pliable than what we gave them credit for. So there is a genetic component to it, but I wouldn't say an inherited direct gene autosomal dominant or recessive transmission.
Yeah. So let's say, you talked about the insulin levels and the blood sugar levels. So let's say if I haven't, an average person hasn't gotten a test done yet, what would be the first signs that that person would experience that could lead to a diabetes type 2?
So the thing about diabetes and the reason it's become so prevalent in the United States, especially in the Western world, now in China, we know in China it's higher as well, and other places that follow a Western type of lifestyle. So the issue with diabetes is usually it's about 10 years between initiation of symptoms and full diagnosis. And that's why we at the Bay Area Wellness Center in Burlingame, we do very early testing for that. So the first sign of diabetes in most cases is not an elevated A1C, which is a typical test they do that shows your 3-month level of blood sugar. The first sign is after meals, a patient can't get their blood sugar down. So again, because of the insulin resistance, now there's a large amount of blood sugar since the patient's eating food and the food breaks down to sugar. Typically insulin released and the insulin shuttles the blood sugar into the cells where it takes care of action, provides energy, and so on and so forth. In type 2 diabetes, you have all this sugar outside the cell in the bloodstream waiting into the cell, but it's like there's a roadblock. You can't get into the cell. So the body says, what's going on? So it releases more insulin to try to overcome this, and then more insulin. So the first thing would be a postprandial blood sugar. This is not always the case. I'm giving generalities. There are exceptions every day, but just to make it kind of simple. So we'd see in a glucose tolerance test, you'd see elevated blood sugars 1 or 2 hours after the meal. So that suggests that the insulin we have is not able to effectively bring down the blood sugar in the blood and get sugar shuttled into the cells.
Got it.
So,
now, before they come to you, like, is that person going to feel fatigue? That's what I was trying to understand. Like, what are the symptoms that person is going to say? Oh, now my blood sugar is shot up, and then they say, oh, I need to go and see Dr. Frank or someone. Like, so what kind of symptoms are they going to start feeling?
So there's a difference. So in our clinic, we test for things that'll show diabetes is coming on in 5 to 10 years. But let's say a patient is new to me,
okay,
and they come in for the full diabetic workup. So they may say, you know what, I find myself peeing a lot. I don't know why, but I don't think I have an infection. It looks clear, but I'm peeing all the time. So that would be one. The other thing would be, like you said, generalized fatigue. Patient says, I don't seem to, don't have the energy. I eat my lunch, and then an hour later I have to sleep. So what happens is, remember we talked about that the blood sugar, insulin is elevated to try to get more sugar. So what happens, it overshoots the mark. So you go from a very high blood sugar, 160, 170, and then the body secretes so much insulin to try to do its job. It takes it down to, 80 or 85, and the patient or the person 1 or 2 hours after the meal, then he feels somnolent. So one of them is they'll say, yeah, about 2 o'clock, I need to take some candy, or I need to take a cup of coffee or a Red Bull because I'm gonna fall asleep. And that's because there's a friability where the patient's blood sugars are not regulated on a small variation. It's a high variation. You go from really high to really low. And when that happens, you go to the low phase, the patient feels really tired. So we have to work with that. So those are the things we see. And then there's other issues as well, but those are some of the major ones we see.
Okay, so let's move on. You've been talking about the tests and the biomarkers. So let's talk about the different tests that you do, as a functional medicine doctor, and also understanding of basic A1C as well.
Right. So again, as I just mentioned, the A1C is the last thing usually to be elevated.
Okay.
Yeah, and
that takes 5 to 10 years, some time before it's elevated, right?
Right. So if A1C comes in at 6.5 or above, they're already a diabetic per criteria, and you've missed an opportunity. I mean, you can still reverse people in early diabetes, but typically we see patients where their blood sugar, their A1C may be as low as 5.1. And if you just get an A1C at 5.1, you go, oh this is great, you're no problem. But I like to see the fasting insulin at 10 or below. And we'll have patients, their insulin's as high as 70. So again, they have it at 5.1, but they've secreted so much insulin that it's a matter of time before the beta cells of the pancreas give up, and then they go into full-blown diabetes. So we look at fasting blood sugar. So remember, let's say we tell you to fast for 10 hours. Well, your body has 10 hours to try to get the blood sugar from your cells into the cells. And if you can't do that in 10 hours, so in other words, when you wake up and you get a finger stick or you get your blood drawn for comprehensive testing, I like to see the fasting blood sugar between 75 and 85. Studies show that above 85 is associated with more cardiovascular and overall mortality. So again, the functional medicine practitioner will look at optimal functional values, not simply reference range, because the patient will say, doc, it says here it's okay to 99. What are you saying 85 for? And again, we don't see reference ranges as the optimal. We look at functional medicine ranges, and we know by many published peer-reviewed data that 75 to 85 is associated with less complications. So if they come in and their fasting blood sugar is 99 or 103, that's not right. If they're really fasting. So then I look for the insulin. And if I see insulin high, then you got two pieces of the puzzle. And I've had A1Cs as low as 5.1. And if you just got an A1C, you say, oh my God, you're doing a great job. Keep doing what you're doing. And it's not. It's that the body's overshooting so much that it's like I said, instead of having a narrow range of blood sugars, which is what humans are evolved to have, you have a wide range of blood sugars, all the way up from close to 200 and all the way down close to 80. That's a little bit abnormal. So finding that, we take action right there. And then if you want to do the gold standard, you can do a 75-gram glucose tolerance test where you check insulin levels plus blood sugar. A lot of times clinicians will just check the blood sugar. Blood sugar is of no value unless you know how much insulin you needed to get that blood sugar. And we'll find if we see too much insulin, but normal blood sugars, that's an early level of insulin resistance, and that's a pre-diabetic. One more thing I should mention. People say, well, my A1C is 6.4, doc. I'm not a diabetic yet, so I can just hang out and do things like before. No, the studies show that once your A1C gets above 5.6, 5.7, you're already having diabetic complications. So you're at risk for having the blindness, the amputations, the chronic kidney disease, the peripheral vascular disease. And again, most diabetics die of cardiac related complications, heart attack, stroke. So it's not good enough to be 6.4. You need to be 5.6, and studies would say 5.4. So that's another way we do early diagnosis, because a lot of times people say, I've never been told this before. So you have to look at outcome data. And that's why I like functional medicine, at least the kind of functional medicine we practice. It tends to be, peer-reviewed scientific studies. And because of that, there's a predictability. Functional medicine, at least in my opinion, needs to follow the same guidelines as traditional medicine. Do we have studies? Are the studies peer-reviewed? Are they in good journals? Is the patient number of subjects to prove the endpoints adequate? Is this a valid study? So we try to give as much science as we can to our patients, so that we're giving good medicine, not just functional medicine, but good medicine. As an internist, it's important to me to follow good medical guidelines. I consider my functional medicine as an additional tool, but not the whole tool chest. It's an additional tool to help us take better care of our patients. So I know it's a long-winded answer, but I hope that answered it.
No, that's really great. So let's talk a little bit about the functional medicine approach versus the conventional medicine approach. We're talking about diabetes right now, so we'll keep the topic within diabetes. If someone who's a diabetic would go to a conventional medicine doctor versus they come to you, what is the difference, and why should they come to a functional medicine doctor?
So it really depends on the alignment of the patient's viewpoint. There's some patients that just want a pill. They say, doc, you know what? Everything you say is probably true. Give me my pill, refill my pill. I'm good to go. So I mean, we can do that if that's what they want. One thing you got to remember, functional medicine is based on individual patients. We don't treat diseases. We treat patients. So if the patient says, doc, you know what? I can't handle it. Just give me the meds. We'll do it. Because again, the patient may come back in 6 months and say, I'm ready now, or they may not. So because it's patient-centered, we don't look at a disease. We look at how can we serve the patient? How can we improve the patient's health outcomes? How can we give the patient more joy? Things of this sort. Okay. I think our sweet spot at the Bay Area Wellness Center is the fact that, being a board certified internist, I'm really comfortable with the medications of diabetes. If they're on insulin, you got to be really careful when you're treating with these medications. And if a practitioner either doesn't have experience or doesn't have a license, then they may not be so comfortable as I am helping with insulin and all the different classes of diabetes medications that have exploded over the last 5 or 10 years. It's been remarkable. So what we do is typically our patients are on 1, 2, 3, 4, 5 medications. They may have a diabetic doctor, they may not, an endocrinologist. So if they come to me and want to look at a more natural or functional approach, then we'll start with trying to improve the terrain, try to improve what their background is. So how are they sleeping? What's their diet like? How much stress is in their life? Are they caring for anybody who's sick or has Alzheimer's? What are they doing to get exercise? I mean, you name it. So there's a lot of things we can do from a lifestyle perspective. So that's one thing. Second thing is, I think in the first years of the 20th century, we do functional medicine and we just overwhelm the patient. You got to do this, you got to do this, you go to this store, get this. And the patient walks out of there with 100 things to do. It's like, I can't do that, you know? So in the last 10 years, we've come up with functional medicine academy coaches, and they really are the go-between between what the doctor says and then what the patient experiences in terms of implementation. I mean, many times I spend 1 or 2 hours with a patient, call them back the next week and nothing was done. And I consider that a failure on my part, because the object is not for me to tell the patient what I know. The object for the patient is to get better. Okay. So usually either a nurse or a high-level coach will come in and help integrate what I've said to the patient and break it down for day-to-day actionable items. And so, you know, we can look at a patient and see they're overwhelmed with all the things we're asking them to change. You're not going to have a successful outcome. And if they're paying cash, or even if they're doing a group visit under an insurance model, you know, we owe it to the patient to give them our best. And you know, the success is based on the patient's ability to change, willingness to change, and to see the numbers go down and the life, the happiness and things of this go down. So that's one thing that's changed probably in the last 5 years.
So for the patients who are able to adhere to the instructions that you give them, or they're following along with some of the health coaches or nurses, have they been able to reverse the, you know, diabetes too with success?
Yes. So again, it's based on the patient, but we have seen a number of patients that were able to get off their medications. Okay.
Yeah.
So this lasts as long as they continue to do the tenets of a healthy lifestyle, exercise, sleep, you know, some nutrients, exercise. We've had patients that got off of it and then they say, oh, I'm cured. And then they go back to their ways, and sure enough, their A1C goes up again. But, you know, we have seen a number of cases, and we have seen patients that have struggled. And that's where I think the health coach comes in, or group visits, something like that. So physician-led or nutrition-led group visits, I think, are the wave of the future. One, because initially functional medicine tended to be, you know, a branch of medicine that was restricted to patients to have a good amount of discretionary income, because it was not cheap.
That's right.
In the last 5 years, it's like, you know what? The patients who need this most are patients who may not have a lot of discretionary income, who are working 1 or 2 jobs, who have a lot of financial commitments, you know. So then we started to have group visits, and then we started to have group functional visits, and then we started to have group nutritional functional visits. So we want to make this available to as many patients that can take advantage of this. If it's only related to people who have a very high level income, you're not going to target a good majority of the people that could benefit from these programs.
Absolutely. So let's just talk about the building blocks to help reverse diabetes. Like you talked about the diet and the lifestyle. So, you know, on a very high level, like if someone is diabetic, they'll have to change their diet, and then lifestyle, exercise, and even supplements. I mean, what are the key building blocks on very high level?
So typically patients will come in and they say, Doc, I don't know why my diabetes is out of control. I mean, look at what I'm eating. I'm healthy oats in the steel cut oats in the morning. And as you know, oats in certain patients, it's like adding the match to kerosene. So it is a carbohydrate. So a lot of times patients, not everybody, but a lot of time patients will benefit from a lesser or ketogenic type diet. Okay. There was a study where it was from, but they put patients on a ketogenic diet for 6 months and actually reversed their diabetes for 3 months. So these are patients did 6 months of a keto diet, stopped it, and then went back to pretty much baseline, allowed them to stay diabetic free for 3 months after that. If they stayed on a healthy protocol, then they reversed their diabetes indefinitely. So we know that in a lot of patients, reducing carbohydrates, especially starchy carbohydrates or processed foods or commercial vegetable oils such as soy, sunflower, safflower, canola, corn, soy. A lot of these oils help with the well, not help, but they contribute to the inflammatory burden of the patient. So we work with that with diet. And then exercise. Patients don't realize you don't have to go out there and run a marathon. If you're sedentary and you're going out there and just walking, that would be beneficial as long as you do it on a regular basis. With the COVID, we've seen a lot of patients either gain weight or have diabetic conditions worsen. So again, we have to be sensitive of where they live. If they can't go outside, then we need to find something they can do in their home. We need to make it doable for them. I think that's the most important thing, is that we listen to our patients. If you tell them, oh, just go to the park, well, their park may be closed or they may feel uncomfortable. So with the COVID really ratcheted up the need to be sensitive to what the patient can and cannot do. Some of them can't go shop at Whole Foods or an outlet that has organic types of food. So you have to go where the patient is, and I think that's where, again, the coach comes in, because they can either send the patient links to where to go or help them with shopping or a lot of different things. Help them with a home exercise program or use something on the internet where they can do 15 minutes or a 7-minute exercise program. So again, we have to keep the patient in the center there so that we can do things that they can actually do.
So I was reading a study actually that weightlifting, lifting weights or strength training, what they call it, is helps the patients with diabetes type 2. There's some study I was reading, there was a correlation that can help. So is there a type of exercises that you would recommend that do, I'm just trying to understand, like, would you say, okay, do aerobics versus weight training versus walking, or is it just move yourself, a level of detail that you go into as a doctor?
Right. So again, it's patient centered. So yeah, I'm aware of the study. And so the study on strength training showed that patients over 60 or 65 benefited from strength training, muscle building, aerobic type exercises. So in younger patients in their 30s and 20s, there wasn't so much of a correlation. So with younger doing aerobic exercise, it helped with mitochondrial regeneration and growth, which helped a lot with outcomes and improving blood sugars and helping with a lot of health parameters. So just generally, as a very general statement, I would say if you're young, then concentrate on aerobic. If you want to do some strength training, you can do it. We don't know if there's enough data yet to suggest improve outcomes. I know there's improved outcomes in terms of certain parameters for younger people. In people over 60 or 65, there's also waste that comes with aging if we don't do anything to reverse it. So when we included strength training in more senior people, that they got a benefit as well. So we would do aerobic for all ages, young and older, but we'd add some strength training to the patients who are in their 60s, 70s, maybe 50s. So again, coach, a lot of times our coaches have some, they may not be certified in strength and conditioning, but they have a good level of effective training for diabetes and other illnesses. So I think it's important that we talk about making sure that you don't try to make bodybuilders out of these people, but we try to just increase their diabetic efficiency, so to speak, by keeping their blood sugars stable. Again, remember, it's the insulin, which is very pro-inflammatory. We need to reduce the insulin.
Got it. So what about the supplements? Do you also recommend supplements, or only the diet and the exercise for diabetes type 2, or?
So we have a number of supplements at Bay Area Wellness Center, but I think the patient really has to understand that supplements are what they say, they're supplemental. You know, I mean, you can't eat poorly at a fast food restaurant and take a few pills of chromium and you'll be okay. So we stress, you know, diet, lifestyle, exercise, stress management, and then we give certain supplements that help with the beta cell regeneration or with reducing insulin resistance or help with balancing blood sugars. We just don't believe that you buy some pill off the counter and you can do whatever you want. I think you're going to be really you know, really disappointed in that. But we do have a number of supplements. But you know, see, the problem is to do everything right may be tough. So the supplement helps to short circuit or reduce the time curve till you get to the you know, associated level of improvement. So again, we may back off because what we hear at Barrow Wellness is, Doc, you got me on 14 supplements. Don't you think it's too much? And we know patients, they're financially or just they're going to burn out. So we tell patients, this supplement you need to take for 2 months. This supplement you need to take for 3 months. This supplement you need to take for the rest of your life. So they have an expectation, but we never say, you know what, do whatever you want. I can just give you supplements. That would be a false, you know, supposition.
So supplement is just a supplement, and the main focus is on the diet, lifestyle, and exercise. And supplement is just kind of, you know, helping a little bit to the next level.
Medicine, food is best medicine. We really try to instill that, you know. And also, I think the other thing about functional medicine, it's a collaborative approach. It's not a top-down approach like traditional medicine 60 was, where the doctor walked in and said, "You're going to do this, you're going to do this, you're going to do this."
Yeah, that's
right. Done now. Half the time, 30% of medications are never filled. So it's our job to really understand what's going on with the patient. And when a patient says, you know what, you gave me that script, I looked over the side effects, I decided not to fill that script. So it was my failure not to communicate better with the patient. Or the patient will say, Dr. X gave me this prescription, I threw it in the wastebasket. So it's really important for us to listen. And if the patient feels they're a partner in it, as opposed to, you know, a fatherly approach where doctor is telling them what to do, I think you get a better outcome, because again, it's their struggle, it's their challenge getting through the diabetes, right? We're just there to coach. And if they're not able to open up with us, I think there's a failure. I mean, a lot of times I'll hear stuff from the coaches that the patient never told me. It's like, I never knew that. So again, we can do a better job as practitioners, I think, to really listen to patients. And I think if we're able to do a functional visit that lasts 30 or 60 or 90 or 120 minutes, we get a lot more than if we're doing a 7-minute visit.
Yeah, which most of us have been used to in the last so many years. You walk into a doctor's office and the doctor comes and you have to, you know, sometimes you have to be so quick in trying to explain, and then a lot of times you forget, and because in 7 minutes there's a hello, you know, hello, how are you doing? That takes about 10 to 20 seconds. So I love this. You know, love this what you're doing, like really understanding it's a patient-centric healthcare model. So so let's say if a patient really follows your guidelines with the coaching, with everything, what is the approximate time frame for if someone can really start feeling much better? I don't want to use the word reversal, even though we put it on the slide, but what they're looking for, 3 to 6 months, or they have to continue? I mean, what is the time frame you're looking for?
If they've been eating poorly, it depends. If they've been eating poorly, probably 30 days, they'll feel the best they've felt in years. Okay.
Wow. 30 days.
Because what happens, what happens is patients are eating oatmeal because they say, well, it was told it was good for me. It helps with fiber. And they may be one of those patients that like oatmeal, like myself. I can't eat oatmeal. It's like eating pure sugar for me. So you can give me any type of steel cut oat you want. I just, my system is sensitive to that. And there's other patients that are like that. They just can't have that. So the trouble is when you tell them, well, we want you to have protein at every meal, they may not be used to eating protein for breakfast. So again, unless you tell them what to eat, they go out of there saying, well, he told me not to eat this, but he didn't give me an alternative. We need to give our patients viable alternatives, you know? So then we have them check their blood sugars. Then like things like juice, they say, well, I saw on the TV a big glass of juice is good for me. So that's pretty controversial, but just in as a generality, I mean, if you're having, you know, a commercial glass of orange juice, it's going to jack up your sugar to a high degree. In fact, remember that when type 1 diabetics have a low blood sugar, what do? They give them a glass of orange juice to raise their sugar right away. So, so we work with them, and again, we do it in a way where we're all learning. The doctors are learning, the practitioners are learning, the patient is learning, and we try to do it in a way where they feel comfortable to ask us questions, because I don't know everything about diet, but I know a few things, and if I can help the patient, or my coach can help the patient, we can get amazing results. They'll lose 7 or 8 pounds. Their blood sugars will be excellent in 30 days. Again, we're not saying you've reversed diabetes. We're saying that you've got less of the yo-yo of the blood sugar around. So it's based on how much input they want to put in. Patients are working 2 jobs. They're taking care of elderly parents. They're homebound because of COVID. They have their salaries been diminished. So we really have to be sensitive to patients where they are, again, because we're not treating a disease, because we're treating a patient, we're working with a patient. Hopefully we have more information to make it a viable type of lifestyle changes that's doable for them.
So the other thing actually was the mind, right? I think there's have been a lot of studies that have been done, how our mind can affect our personal health. So is that also mindfulness, meditation, is that also part of your overall protocol that you talk about to the patients?
Right. So initially we would recommend some apps for like meditation or yoga. I think we're in the process of trying to do something that the patient simply logs on to, and we can help direct that. We're not there yet, but the idea would be to give them a few choices. The other thing is people work during the day, they work during the night. You need to have something that's flexible enough. But stress is at the basis of 80% of primary care medicine. And in a 7-minute visit, you'd be surprised what you miss. And we've learned some things about our patients that we didn't know. Patients have been with us for 5, 10, or 20 years. So being able to spend more time with them has been a blessing for me, and hopefully the patient's gotten some benefit, because they're not going to get into depression in 7 minutes. In 60 minutes, they all do. I've had 3 patients this week. So, doc, I think it's about time we discuss my depression. And it's like, kind of out of the blue for me. And we were able to spend 30 minutes because I had like a 2-hour visit with them. So we talked about alternatives for that. And I think if you miss that, then, I don't think you're a skilled a healer, because we really need to know where our patients are coming from. I mean, before the COVID, we would do home visits on occasion, and it was very enlightening.
That's great. It's excellent. Any questions from anyone, you're welcome to ask. Anyone can also, I think I forgot to put our email and website here, but nourishtalk.com and care@nourishtalk. You can send, emails or inquiries. And thank you so much for Dr. Frank for being with us today. Anything else you'd like to add before we wrap up today?
Again, I would say for patients who resonate with this type of functional medicine, that they can find doctors. They can go to IFM, and there is group visits. So if they don't have a lot of discretionary income, there are doctors doing group visits, and that's made it affordable, sometimes as low as $25 for a group visit or a session, because I think, United States is 37th in health outcomes, and that's really poor for them. We're the number one in expenditure per patient. We're 37 in outcomes. That's just not good enough. So by doing medicine, we want to improve the health of our communities, and our health is sacred. If we can partner with somebody who believes that, then I think we can go further down the line.
Well, thank you so much for being with us. I think it's an excellent interview, and I hope to all our viewers it helps you listening from MD on diabetes. So let us know, help us share these sessions, and let us know your feedback. With that, I'd like to wrap up this session right now, and thank you so much, Dr. Frank, for being with us.
Thank you.
Thank you. Bye-bye.